nuclear medicine approaches in the field of oncologic pediatric surgery, and review the risk factors for pediatric thyroid nodules. Nilofer Bikaxi, Guler-Silov, Unal Bikaxi, Fadi-Badi, Banu Kurtiloglu. Use of F18-FDG Peru time/central time in childhood malignancies. As the incidence of cancer in the childhood age group is lower than that in the adult age group, the incidence of childhood cancers is defined as per million. According to European data, it was reported to be 140 per million in the 0 to 15 age group and 157 per million in the 0 to 19 age group. According to between 2014 to 2018 data from the Department of Cancer of the Public Health Institution of Turkey, the incidence of cancer in boys and girls aged 0 to 14 years is 10 to 50 per million, although it varies according to the type of cancer. Although the incidence of childhood cancers is low, it has serious clinical importance since it is the second most common cause of death in this age group. The most common childhood malignancies are leukemias 30%, central nervous system and brain tumors 20%, lymphomas 14%, neuroblastoma 7%, soft tissue sarcomas 7%, Wilms tumors 6%, bone tumors 5%, germ cell tumors 3%, retinoblastoma 3%, melanoma 3%, and hepatic tumors 1%. Fluorine 18-fluorodeoxyglucose positron emission tomography/computed tomography, F18-FDG Peru time/central time, plays an important role in the diagnosis, staging, restaging, response to treatment, and evaluation of prognosis of childhood malignancies. F18-FDG Peru time/central time is a non-invasive molecular imaging method that reflects the metabolic properties of the tumor, along with its structural status. F18-FDG Peru time/central time is being used with increasing frequency in the diagnosis and follow-up of childhood tumors, but the imaging procedure, patient preparation, and calculation of radiation doses require greater care than in the adult age group. It is important to ensure sedation during imaging in pediatric patients. The practice guidelines of the American Academy of Pediatrics can be considered as a guiding example in this regard. In addition, to prevent harmful effects due to radiation, it is necessary to be more careful when calculating radiation doses compared to the adult group. In 2010, the North American Consensus Guideline was published, and the radiopharmaceutical doses to be applied were determined. Childhood lymphomas in F18-FDG Peru time/central time. F18-FDG Peru time/central time is a functional and metabolic imaging method that plays a major role in the staging, treatment response evaluation, and residual/recurrence detection of HL and NHL. The sensitivity, specificity, and accuracy, 95.9%, 99.7%, and 99.6%, respectively, of 18F-FDG Peru time/central time were found to be higher than those of other conventional imaging methods, 70.1%, 99%, and 98.3%, respectively, for initial staging of lymphoma in children. Sympathetic nervous system tumors in F18-FDG Peru time/central time. Neuroblastoma (NB) is the most common tumor in this group, with 90% of cases diagnosed by the age of 5 years. The use of F18-FDG Peru time/central time in the diagnosis, staging, and evaluation of response to treatment is limited. In a study, it was reported that F18-FDG showed moderate uptake in the methiodobenzoguanidine (MIBG) and plus groups and was not as successful as MIBG in showing bone and bone marrow metastases. Treatment modalities for NB usually include 4 to 6 cycles of induction therapy, followed by surgical resection and radiotherapy to the primary site and other active residual disease sites. A recent study evaluated the benefit of surgical resection in a subgroup of patients with poor response to induction therapy. Tumor volume greater than 50% of the initial volume after 6 cycles of induction therapy. The results showed a statistically significant improvement in the 3-year overall survival of patients who responded poorly to induction therapy and underwent tumor resection, compared with those who did not undergo surgery. The promising MIB-global PET radiopharmaceuticals, F18-DOPA, 18FL3, 4-dihydroxyphenylalanine, GA68 dotapeptids in NB are important for guiding high-dose therapy with 131 MIBG and Lu-177 dotapeptids. Wilms tumor in F18FDG Peru time/Central Time. Wilms tumor nephroblastoma is the fourth most common tumor in childhood. Although its etiology is unknown, genetic diseases are associated with 5% of the cases. The overall 5-year survival rate exceeds 90%. Tumor staging, such as tumor location, size, local extension, vascular compression or invasion, and local lymph node metastases, are best assessed by CT, MR imaging, and ultrasonography. The most common site for metastases is the lungs, which are typically assessed by chest CT. Therefore, the use of F18FDG Peru time/Central Time for diagnosis and staging has been limited. Wilms tumors show strong 18F-FDG uptake. The mean SUV has been reported to be 6.8. Anaplastic Wilms tumors showed particularly high 18F-FDG uptake, and the SUV max value greater than 5 was due to the highly expressed glucose transporter 1. Apart from this, no significant correlation was found between 18F-FDG uptake and tumor histopathology. F18FDG Peru time/Central Time appears useful for assessing the response to treatment. Rhabdomyosarcoma and F18FDG Peru time/Central Time. Rhabdomyosarcoma, RMS, arising from embryonic mesenchymal cells differentiating into skeletal muscle, accounts for 20% of all solid tumors in children. Although the cases are sporadic, some congenital and genetic diseases increase the risk of RMS: Li-Fraumeni syndrome, Beckwith-Wiedemann syndrome, neurofibromatosis type 1, Costia syndrome, Nguyen syndrome. There are embryonal and alveolar histological types of RMS, and the incidence in boys is slightly higher than that in girls, male/female ratio of 1.51. In the past, aggressive surgical methods such as amputation and pelvic and orbital exenteration had an important role in the treatment of RMS, but in the current treatment of RMS, organ-preserving surgery with chemotherapy and radiotherapy is at the forefront. The survival rate, which was 25% with radical surgical treatment, increased to 70% with the addition of radiotherapy and chemotherapy to the surgical treatment. F18FDG Peru time/Central Time is used in RMS to determine the malignancy potential of the lesion, biopsy site selection, staging, and evaluation of response to treatment. This group of tumors showed high FDG accumulation, which increased as the tumor grade increased. Although F18FDG Peru time/Central Time is not routinely used for initial staging in pediatric RMS, it is specifically used for the detection of nodal involvement and distant metastatic spread. For nodal involvement, F18FDG Peru time/Central Time showed a sensitivity of 80% or 100% and specificity of 89 to 100%. F18FDG Peru time/Central Time has a higher chance of detecting lung metastases larger than 1 cm in bone and bone marrow metastases than conventional methods. For the detection of distant metastatic sites, PET-CT has a sensitivity of 95% or 100% and specificity of 80 to 100%. Review of risk factors for the management of pediatric thyroid nodules. Clinical risk factors for pediatric thyroid nodules. The incidence of childhood thyroid cancer is increasing recently. Despite the rapid increasing incidence, pediatric thyroid cancers constitute less than 2% of all thyroid cancers. Owing to the high prevalence of thyroid cancer in adults, the main diagnostic and prognostic criteria for thyroid cancer have been developed for adults and were adapted to secondarily applied to children. The American Thyroid Association, ATA, and American College of Radiology Thyroid Imaging Reporting and Data System, ACRT-IRADS, for reporting sonographic findings, and the Bethesda system for reporting thyroid cytopathology, TBS-RTC, were both developed the management of adult thyroid nodules, but are widely used the classification of thyroid nodules in children. Differences in the underlying biology of thyroid tumors between adults and children may affect the risk of malignancy, RAM, predicted by various sonographic and cytopathological findings. Although thyroid nodules are detected at a much higher rate in adults than in children, they are 5 times more likely to be malignant in children, 26.4%, than in adults, 5%. Radiation exposure, autoimmune thyroid disease, and chronic iodine deficiency are well-established risk factors for the development of thyroid malignancies in both adults and children. Childhood thyroid cancer is often diagnosed at a more advanced stage compared to adults, and is more likely to develop regional lymph node and lung involvement and higher recurrence rate. Distant metastases almost always occur in the lungs. These are diffuse and are usually identified by I-131 whole-body imaging. Despite more advanced disease at presentation, children with thyroid cancer have a much lower death rate, with overall cumulative survival rates as high as 97 to 99%. The majority of thyroid cancers in children are papillary thyroid carcinoma, PTC, 80 to 90%, followed by follicular thyroid carcinoma, FTC, 10%, medullary thyroid carcinoma, MTC, 3 to 5%, anaplastic thyroid carcinoma, ATC, and poorly differentiated thyroid carcinoma, PDTC, are rarely encountered. ATC is a dedifferentiated thyroid cancer via transformation of differentiated thyroid cancer. IT is extremely rare in children. Poor outcomes in children are largely due to regional and distant metastases, rather than the local spread of dedifferentiated tumors as seen in adults. Genetic risk factors for pediatric thyroid cancer. Recent molecular profiling studies have suggested that thyroid cancer in adults and children has different developmental origins, which may explain their different clinical characteristics. PTC is the most common histological type of thyroid cancer in both adult and pediatric populations, although the histological subtype frequencies are different between children and adults. Notably, BRAF V600E RAS, mostly HRAS and NRAS point mutations, and gene fusions are mutually exclusive causes of DTC. Unlike the adult thyroid cancer profile, there is a high prevalence of gene fusion in pediatric PTC. RET NTRK1, NTRK3 ALK, BRAF ACAP9, and MET gene fusions are among the most common in pediatric PTC. However, there is a lower frequency of point mutations in the RAS, BRAF, and GNAS genes in children with PTC than in adults. Specific fusions tend to be associated with different histological subtypes of pediatric thyroid cancer. For example, a CAP9-BRAF is a less frequent BRAF alteration associated with classic papillary histology, whereas PX8-PARC has a follicular histology. Pediatric PTCs associated with fusion mutations have a higher frequency of aggressive subtypes, including diffuse sclerosing, tall cell, and solid variant. RET PTC rearrangements are associated with solid PTC variants. Rearrangements are typical in pediatric patients with radiation-induced PTC. Between 15 to 19 years of age, fusion mutations decrease and point mutations potentially lead to dedifferentiation, and radioactive iodine resistance begins to increase as in adults. Genetic syndromes are also known risk factors for pediatric thyroid cancer, accounting for approximately 5% of all pediatric DTC cases. Some of the more common syndromes affecting the thyroid include PTN hamartoma tumor syndrome, APC-associated polyposis, e.g., familial adenomatous polyposis, Carney complex, Dicer-1 syndrome, and Werner syndrome. Medullary thyroid cancer (MTC) is frequently associated with mutations in the RET proto-oncogene and accounts for 5% of all pediatric thyroid cancer cases. Most MTC cases in the pediatric population are hereditary, with germline RET mutations resulting in multiple endocrine neoplasia, MEN, type 2A syndrome, 90 to 95% of childhood MTC, MEN type 2B, or familial medullary thyroid carcinoma, FMTC. Adult tumors caused by gene fusion do not usually progress to more aggressive diseases. Rather, progression of adult thyroid cancer involves the accumulation of additional point mutations associated with local disease spread, metastasis, and transformation to aggressive dedifferentiated anaplastic and poorly differentiated subtypes. PTC progression is associated with the inclusion of other secondary gene mutations such as TP53, PIK3CA, and AKT1. These secondary mutations are extremely rare in children and have not been detected in several recent large-scale sequencing studies on pediatric thyroid cancer. Ultrasonographic risk classification, ultrasonography (US), is the most commonly used imaging modality for detecting thyroid nodules, measuring nodule size and determining nodule shape, borders, location and number, echogenicity, content, and assessment of associated changes in the thyroid gland. Multiple risk classification systems based on U.S. features of thyroid nodules have been developed to provide general terminology for the identification and classification of nodules at the greatest risk of morbidity and avoiding biopsies of benign nodules. The ability of the ACR-TI-RADS to accurately predict the risk of malignancy in pediatric thyroid nodules is currently unclear, as it was predominantly validated using adult data. However, recommendations for the evaluation and management of pediatric thyroid nodules have historically been based on the adult guidelines. One of the two most widely used systems in clinical practice is the ACR-TI-RADS, which is used by many radiologists, and the other is the ATA guidelines, which is used by many endocrinologists. ACR-TI-RADS summarizes this by scoring each of the 5 ultrasound findings: composition, echogenicity, shape, border features, and echogenic foci of the nodule, and defines the risk levels from TR1 to TR5. Fine needle aspiration biopsy, FNAB, is recommended for TR3 nodules greater than or equal to 2.5 centimeters, TR4 nodules greater than or equal to 1.5 centimeters, and TR5 nodules greater than or equal to 1 centimeter. The biopsy and follow-up criteria according to ACR-TI-RADS are summarized in Table 1. The 2009 ATA Adult Guidelines indicate that the evaluation and treatment of thyroid nodules in children should be the same as those adults. The 2009 ATA Adult Guideline states that FNAB is not necessary for nodules smaller than 1 centimeter, unless they are high risk, has a history of ionizing radiation, or have a pathological regional lymph node. However, the size criterion in children is more problematic because thyroid volume changes with age and nodule size alone does not predict malignant histology. Therefore, U.S. features of malignant lesions, such as hypochogonicity, irregular borders, microcalcifications, increased intranodular blood flow, and clinical signs, should be given more importance in defining nodules requiring FNAB. U.S. evaluation of cervical lymph nodes should be performed in all children with suspicious nodules. It should also be noted that in the diffuse sclerosing subtype, which is invasive form of PTC, the tumor shows diffuse microcalcifications without nodules or macroscopic metastases in the cervical lymph nodes. Evaluation of pediatric thyroid FNAB cytopathology with the Bethesda classification system. US is often the first step in imaging thyroid nodules. ACR-TI-RADS is a well-established tool for evaluating the risk of malignancy in adult thyroid nodules, but its application to pediatric thyroid nodules is still in progress. Thyroid nodules that are suspicious on US underwent FNAB for differential diagnosis to guide further management decisions. As cytomorphology does not always provide a clear difference between benign and malignant lesions, it is important to have specific diagnostic criteria to stratify the ROM of thyroid nodules based on FNAB results. TBS-RTC had been developed and published in 2010. Among the TBS-RTC categories, atypia of undetermined significance, AUS, follicular neoplasm, FN, and suspected malignancy, SM, were considered indeterminate. TBS-RTC was first updated in 2017 to include non-invasive follicular thyroid neoplasm with papillary-like nuclear features, NIFTP, as a new histological entity, which may alter the ROM of adult thyroid nodules. A pediatric cohort study reported that the performance of TBS-RTC in pediatric populations is unlikely to be affected by the addition of NIFTP. The third edition of the TBS-RTC was released in 2023 with updated ROMs. The new TBS-RTC includes 2 subclassifications of AUS, AUS nuclear atypia and AUS other. In addition, for the first time, the new TBS-RTC includes information on its application to pediatric thyroid nodules. Differences between guidelines have highlighted the need for new methodologies to classify the risk of indeterminate thyroid nodules in pediatric populations. In the third TBS-RTC, AUS is divided into 2 main groups: AUS with nuclear atypia and AUS with any other form of atypia, AUS other. In a retrospective cohort study of 68 pediatric AUS thyroid nodules, there was an increased ROM when there was nuclear atypia, 59% for nuclear atypia versus 6.5% for architectural atypia. The highest ROM was observed in the nodules with both nuclear and architectural atypia, 75%. The results of this study demonstrate that risk stratification of AUS pediatric thyroid nodules by atypia type may identify a subset of nodules that require surgical management and reduce overtreatment of nodules that do not have nuclear atypia. Molecular techniques for risk stratification of indeterminate thyroid nodules. Recently, there have been rapid developments in cytomolecular testing to reduce the need for Bethesda 3 and 4 diagnostic surgery. The Afirma-genomic sequencing classifier Afirma-GSC and Thyroseq3 TSV3 performed well, similar to undiagnosed FNAB results, Bethesda 3 and 4. TSV3 was found to have a relatively high sensitivity and negative predictive value of 90% and 96%, respectively. However, their diagnostic confirmatory performance for malignancy remains limited. Although the use of molecular techniques is increasing, the cost of molecular testing remains the most important problem. The rate of structural malignancy in BRAF 600E positivity alone in intrathyroidal micropapillary cancer was approximately 1 to 2%. Bilateral thyroidectomy, lymph node dissection, and RAI treatment are recommended for BRAF-positive intrathyroidal tumors. Active follow-up may be considered for BRAF-negative micropapillary cancers, and lobectomy may be considered for BRAF-negative or BRAF-positive micropapillary cancers. In patients with BRAF V600E plus TRT or RAS plus TRT promoter mutations, aggressive treatment approaches are selected, even if micropapillary cancer is present. Conclusion: there are many risk stratification systems according to the U.S. characteristics of thyroid nodules, and the most widely used in clinics are the ATA guidelines and ACR-TI-RADS. FNAB is the gold standard for evaluating nodules according to U.S. risk stratification. TBS-RTC is the most widely used cytomorphological classification for FNAB. The last TBS-RTC reporting system covering the adult and pediatric populations was updated in 2023. Recently, there has been a trend towards the use of molecular testing of FNAB specimens, especially those diagnosed as Bethesda 3 and 4, to reduce the need for diagnostic surgery and to guide treatment. In conclusion, an excellent prognosis for pediatric DDC may be possible with a review of diagnostic processes and management guidelines for pediatric thyroid cancer.